one of the chairmen of this meeting. So on behalf of the meeting, I would like to extend my warmest welcome to all of you who come all the way from different parts of the world and join this meeting. So this is the fourth Bridging the Gap meeting. So it's been, the first two was held in Singapore, and the last one was in Hong Kong. So actually throughout these years, we see tremendous advances in terms of the content of the meeting and also the attendance of the meeting. So actually, for instance, the attendance of the first two meetings in Singapore was around 200, and it escalated to around 450 last year. And I'm sure there is a further increase in this attendance in this year. So actually, we are very happy about the progress. And moreover, I believe that all of you who actually came over from other places will find that this time of the year is actually the best time of the year in Hong Kong. So you find that actually the weather is fine and it is warm, especially for those who come from a long way that it may be snowing in your home country. So riding on the success of the last three meetings, so basically, again, we have a lot of very interesting topics, and that integrates basically all the advances, the recent advances in terms of the novel agents, targeted therapy, and new clinical trials in all aspects of hematological malignancies, including leukemia, lymphoma, and myeloma. And I'm sure that all of you will enjoy this. And one of the, I think, important feature of this meeting is that we've got simultaneous sections if you look at your program book. And I think this is very important because we make it more compact, and actually all the attendants actually who are interested in different areas can actually go to different simultaneous sections. And because of that, the section may be smaller, but I think the good thing about it is that all of you can interact with the speakers more closely. I think this is one of the important features of this meeting. And as usual, we have a very distinguished faculty of speakers this year again, so you can read in your program book. So I believe that this is it's going to be a very inspiring, educational, and stimulating meeting. So I hope that all of you will enjoy the meeting, will actually develop fraternity with all the attendants from other countries, and you will get acquainted with distinguished speakers from all over the world. So moreover, I would also hope that you will enjoy your stay in Hong Kong, because Hong Kong is a very nice place, and this is the weather is very good, and this is a very safe place. So I hope that you will enjoy the meeting, and also you will enjoy your stay in Hong Kong. Thank you very much.
Hello, I'm Richard Champlin from the MD Anderson Cancer Center. I'm happy to welcome you to another one of these BTG meetings. We're really very excited about the prospects of discussing hematologic malignancies with you again this year. Just reflecting how fast this field has developed. You know, when we had these meetings over a decade ago, we were talking about, well, is there anything better than melphalan and prednisone for myeloma? What's the dose of Ara-C that you give for acute myeloid leukemia? Should we do interferon or bone marrow transplant for chronic myeloid leukemias? And all those questions are well behind us now. We're now in an era of personalized medicine with exciting molecularly targeted therapies. There's been advances in transplantation. We can now do cord blood transplants and haploidentical transplants, so everyone has a donor for a transplant. And there's just tremendous excitement as we try to sort out how do we integrate the novel agents, how do we integrate advances in transplantation into our standards of care. It's great to come to Asia. The spectrum of hematologic malignancies is obviously different here than they are in the United States. It's a great educational opportunity for me and others from the US to come and see the spectrum of disease that you have here. And also it's a challenge for all of us in all parts of the world. How do we integrate these very expensive but effective novel therapies into our care? This is a problem in the United States, and certainly a problem in the economically developing world. So again, I'm very excited to be here. I think it's going to be a great meeting, and that we'll look forward to working with you. Thank you.
Good morning, everyone. I'm Morton Coleman, representative of Weill Cornell Medical College and the New York Presbyterian Hospital. On behalf of the medical group, I want to invite you and welcome all of you to the 4th International Conference on Hematologic Malignancy, Bridging the Gap. We make a great effort to make this meeting exciting, informative, and memorable, and we do need your help. Please give us your criticisms and also offer us your compliments. A great deal of effort has been put into making this meeting everything that you want it to be by a number of people, all of whom I cannot begin to mention here this morning. Now for some housekeeping rules. Please turn off your pagers and cell phones, or at least put them on silent alert. Another very important bit of information, the bathrooms are to my right and to your left, and that's a very important bit of information for everyone. Now, let's talk about today's meeting. First off is the plenary session will go from 8 o'clock in the morning till noontime. Lunch session will be from noon to 2 p.m. Workshops will range from 2 p.m. to 5 p.m. This afternoon. Poster presentation and exhibits booths will be in the foyer, so please attend the exhibitors and please look at the abstracts as well. And tonight we have an exciting program for you. Starting at 6:30 will be the APHCON President's Reception in the JW Marriott California room. And that will go on from 6:30 to 7:30. And all here are welcome to the President's Reception. From 7:30 to 8, there will be entertainment including the lion dance, the tarot reading, and calligraphy. And from 8 o'clock on will be the buffet dinner. All are invited to the President's Reception. Now it gives me great pleasure to introduce to you Professor Xiaojun Huang, who is President of APHCON. Dr. Huang.
Dear ladies and gentlemen, good morning. I'm Dr. Xiaojun Huang from Peking University. I'm one of the member of the organized committee, so I would like to express a welcome to all of you to attend the BTG 2013. Then I will like take this opportunity to give a short, brief introduction on the update of APHCON, Asian Pacific Hematological Consortium. As you, all of you might know, this is a relatively new, but the new organization, but it was established just last year. But the progress, the organization has achieved great progress during this very short time. As here you know, the membership was started started on August 2012. During only within half a year, we have currently more than 10,000 members from 19 countries. So the philosophy of APHCON is that cooperation with existing hematological society provide cooperation framework for clinical trials, education, and training exchanges. So we have different division. Here, Dr. David Richard, who is from Australia, but he is the chairman of the Clinical Trial Network. And also, Subhas Verma, he is the chairman of APHCON Preceptorship Program. Actually, during this meeting, the winner of preceptorship will be announced during this meeting. And also Surapong, who is the chairman of the society relationship of APHCON. And also Dr. James Chen, he is the chairman of Clinical Practice Guidelines. And Panka Mahatara, who is the chairman of APHCON membership. Actually, this is just Pama told me this is a private network. All the membership can get access to the network. And then every member can have the ID. I think the member of APHCON will get his your ID member soon after this meeting. And then with this network, you can talk with the member of APHCON, and also you can slowly this network access to the medical journal. I think 3 months ago, I told my colleague in China they can get access to the medical journal, but because of some security problem, this has a little behind the security because once you access to the one of the journal, you can get access to the all kind of journal. That will be some problem. So I think that I don't know that teach knowledge problem, but Pam told me they have some solution for this problem. So I think after this meeting, we can get into the access to the journal. The journal is Blood JCO, Leukemia, Lymphoma. Actually, the abstract of the BTG meeting was published in Leukemia Lymphoma Journal. Here is the Leukemia Lymphoma Journal. Here is the sum of member. I think many of them you are familiar with many of them. Here is Pamela. I think she do a lot of the work for this meeting. And another program is that progress is that APHCON has actually have formal cooperation with global academic program from MD Anderson. I think Dr. Kian will address the potential or undergoing cooperation within APHCON. He will address the cooperation during this meeting. So this is the update of APHCON. I think with everyone's joint effort, I'm sure the APHCON will have better future. This is I think this evening's reception. Welcome everyone to attend to the reception. Thank you.
It now gives me great pleasure to introduce Professor Ang from the MD Anderson Hospital, who chairs the Global Academic Program for the MD Anderson. Dr. Ang.
Good morning. It's a pleasure to be here, and I'm bringing you greetings from all members of GAP, we call it, stands for the Global Academic Program. And I think our goal is really to bridge the gap between MD Anderson and sister institutions. And the goal that we really share with you. And this program has been working since 2002. And we have some accomplishments, and I'm going to show you an example of what we have done, and then look into ways to really interact with you and see what we can do together. So the mission of GAP is to facilitate and administer MD Anderson's sister institution network, working collaboratively on mainly education first, but we have started some research and patient care aiming to lessen the world's cancer burden. So this is the map of our sister institutions. You can see that there are about 3 groups. One is in Latin America. We have sister institutions in Europe, and there are many in Asia as well. So we have the necessary connections here, and We have 26 active members, and there are several in application that we will process during the next couple of years. Now, as a part of a pilot project, we started, this is started by my predecessor, Dr. Bogler, the so-called Sister Institution Network Funds, and part of it is provided by the MD Anderson funds, but it is matched by the sister institutions in a ratio of 1-to-1. And we also started working with other organizations, and an example is the National Breast Cancer Foundation that has given us $300,000, mainly to help develop cancer treatment in Africa. And this seed funds has already generated interesting results. And this is plotting the joint publications between MD Anderson faculty and our colleagues in the network. You can see that the collaboration started many years ago because we have had many postdoctoral fellows spending time with us. But since the inception of GAP, you can see the number of publications has gone up dramatically, and now we have a total of over 600, and this list will expand very rapidly. More interestingly, as the results of the seed fund, we have had many high-impact publications, and a couple of them are summarized here. So we hope that this program will be successful. We know many investigators have competed successfully for other grants based on the work done with the seed money. Now, since we are in Hong Kong, I would like just to give you a vignette showing how collaborations developed, and this is particularly relevant as you can see that this is a partnership between MD Anderson, the Chinese University of Hong Kong, Chang Kung University, and National Taiwan University, and it is in partnership with a cooperative group, the RTOG. Now, NPC is, of course, of particular interest to me because I was born somewhere here, then moved with my parents to Indonesia. So I'm in the highest risk group. So I'm particularly interested in following the progress of this disease. And the reason we have chosen this partnership is manifold. As you know, there are many patients over here. We have the quality assurance program developed at MD Anderson, in addition to having some patients. And the RTOG, of course, is equipped to run clinical trials. Now, this is the data summarized by a colleague, Dr. Lee, from Hong Kong, of the findings of the registry that was started by the late Professor John Ho. Many of you know is really Mr. NPC. And you can see that before 1950, nobody survived NPC over 5 years without a recurrence, and the main pattern of recurrence is local regional progression. And the results have improved dramatically over the years, as shown here. So the question we first asked is this improvement ascribed to diagnosing the disease earlier and earlier? So Dr. Lee went back, looked at the staging at presentation around the year 2000. And she found that even only 10 years ago, close to 5% of patients had already had distant metastases at the time of presentation, and the majority had stage 3 or stage 4A or B. So the answer to that question is, unfortunately, we are not diagnosing this disease earlier. Then we start to ask, has the treatment had something to do with this improvement? And since surgery had no role in the treatment of nasopharyngeal carcinoma, we look at the development in radiotherapy, and as you can see here, we could really relate the stepwise improvement to the development of technology in the first 2 curves here. Cobalt was introduced, linear accelerator, and more recently, we know how to add chemotherapy and how to refine radiation. So we are at a stage that we can say that standard of care of locally advanced NPC is intensity modulated radiotherapy plus cisplatin, followed by adjuvant chemotherapy, and this standard therapy came from 2 important studies, along with many confirmatory studies. This is the first trial showing the benefit of adding chemotherapy, and this is the first publication by Dr. Lee showing the role of precision radiotherapy. And now the results of many trials show that even in patients with locally advanced disease, we can control the tumor locally very well, and we are starting to lose patients on distant metastases. So we have completely changed the natural history of this disease. Now, our colleagues at the Chinese University of Hong Kong has come up with this very, very strong prognostic marker that is the circulating post-treatment EBV DNA titer. And if the titer after treatment is low, the patient survived well. If the titer remains high, almost all of them died of the disease. And I'm just going to summarize to you in 2 or 3 more slides here, saying that how do we take this information forward? And what we think is summarized in this trial design. So in patients with locally advanced NPC, our plan is to start with IMRT with cisplatin. The standard of treatment is to move then to adjuvant therapy. But we think we can put in a marker assay after this initial component of treatment. If EBV titer decline to 0, we think that these patients is already cured. So they do not need the adjuvant chemotherapy that is pretty toxic. But if the titer remains high, then we think it is not logical to continue with cisplatin because they have already received many cycles. So the tumor is likely to be cisplatin resistant, so they are randomized to receive the standard or other chemotherapy for the time being. But we are also working on therapy strategies targeting the virus. Now, in order to do this trial, we had to complete 2 assignments. One is to make sure that the radiotherapy is delivered properly. The other is to standardize assays. So the assays done in the US will give the same results as the assay done elsewhere. So this is just briefly the quality assurance program. We work with our physicists. They are located at MD Anderson Cancer Center. We had fun designing a phantom. In the phantom, we put in 3 target volumes. These represent the primary tumor. The second one represents the brainstem or spinal cord, and the third one represent the nodes, and we give them specific dose to deliver to these structures. So we send the phantom to the center. They need to do simulation CT scan. They need to do dosimetric planning, and they have to irradiate the phantom and send it back to us. And these are just two examples of a center that has done an outstanding job. You can see they were able to deliver high-dose radiation to the target, sparing the spinal cord, and give slightly lower dose to the second target. And this is an example of a center that failed miserably. And we worked with the center to look at what went wrong step by step, and they were able to correct the mistakes. And this is just a reflection that when you are planning a trial well, before a single patient enrolled into the trial, we are benefiting the treatment of cancer patients already, because this center clearly can treat radiation better now. And the second assay, just to show you that we have harmonized the assay. It took us 2 years, and this paper is in final revision in the clinical cancer research. So I hope I've conveyed to you the efforts that we have done, experience we have gained, and we will be very happy to partner with you moving forward. Thank you very much for your attention.
Thank you very much, Professor Ang. Now we need to find out a little bit about you folks, and so please use your ARS devices at the table as we ask you questions about where do you come from to begin with. What country do you practice in? 1, China, 2, Japan, 3, Korea, 4, India, 5, Thailand, and 6 other. Maestro, do we have any background music? And let's see, are we going to give the answers out? Well, it looks like the #1 country is China, followed, I guess, by other. And third place would be Thailand. Next question, please. Your gender is 1 male, 2 female, and 3 other. In today's world, that's not such a novelty anymore. We have, again, a preponderance here of a male. No surprise in looking at the room. Next question, please. Your age is 1, 20 to 40, 2, 40 to 60, and 3, 60 or above. Well, it looks like the younger generation is taking over. What's wrong with this picture? I'm more than 60 and I'm in a great minority. It's a very small minority. Next question, please. How many new MDS patients do you see each year? 1, less than 5, 2, 5 to 10, 3, 11 to 15, or 4, more than 15? Good Lord, you guys are really busy. Again, it looks like a plurality of you will see more than 15 MDS patients. I don't know what's going on in the water here in Asia. Next slide, please. How many new multiple myeloma patients do you see each year? 1, less than 5, 2, 5 to 10, 3, 11 to 15, and 4, more than 15. You folks are really very busy, more than 15. Can we put that back up again? How many, do we have the slide on how many multiple myeloma patients do you see? I think I saw that the majority of them were more than 15. Oh, there we go. Okay, so it seems as though you see between 11 and 15 patients, and more than 15 patients a year. That's quite a number of patients for general oncologists. Next question, please. How many chronic lymphatic leukemia patients do you see each year? 1, less than 5, 2, 5 to 10, 3, 11 to 15, and 4, more than 15. I think this depends on where you are in Asia. Maestro? Yeah, apparently chronic lymphatic leukemia is not very prevalent in, I guess, Southeast Asia. I guess there are some patients that you can find in India. Next question, please. How many lymphoma patients do you see each year? 1, less than 5, 2, 5 to 10, 3, 11 to 15, and 4, more than 15. More than 15 patients. Good Lord, we should ask you, how many patients do you see in a week? Next question. How many new CML patients, chronic myelocytic leukemia patients, do you see each month? Less than 5, 5 to 10, 11 to 15, and 4, more than 15. Less than 5 is a plurality here. All right, next slide, please. How many new aplastic anemia patients do you see each month? 1, less than 5, 2, 5 to 10, 3, 11 to 15, and 4, more than 15. Pardon? Less than 5. That makes sense. Next question, please. What is your standard induction therapy for elderly AML over 60 years old? That depends on what age you are, whether the elderly really starts at 60. 1, 7 and 3 induction, 2 RSC-based regimen, 3 demethylating agents, and 4 other. So most of you use an RSC-based regimen. I'm surprised that more of you, well, I guess 7 and 3 may be a little bit too toxic for those who are elderly. Again, my definition of elderly is 1 year older than I am. Next slide, please. Do you offer allogeneic transplant for elderly AML, that is patients over 60? 1, yes, 2, no. No. Well, that's interesting. We'll see what your attitude is after these sessions. Next slide, please. Stem cell source of choice. When donor options are limited. 1, haploidentical donor, 2, cord blood, or 3, none of the above. Haploidentical donor. That's interesting. I wonder how many of you folks have a cord blood program. Next slide, please. ATG is part of conditioning regimen for haploidentical transplantation. Yes, it is. 2, no. 3, I don't know. I don't do haplotransplants. Maestro? Yes. Okay, good. Next slide, please. Preferred regimen for graft versus host disease prophylaxis. Tacrolimus methotrexate, 2, tacrolimus MMF, 3, sirolimus-based regimen, and 4, none of the above. So most of you use tacrolimus and methotrexate. Okay, next slide, please. Treatment of choice for steroid refractory graft versus host disease patients. 1, pentostatin, 2, extracorporeal photopheresis, 3, ATG, and 4 others. Well, it almost is an even split between 2 and 3 extracorporeal photopheresis and ATG. Next slide. What is your treatment of choice for standard risk ALL in first CR? A, upfront allogeneic transplant if sibling donor is available. B, induction chemotherapy followed by maintenance. And C, other. Well, again, we have pretty much of a close split between A and B. Next slide, please. What is your preferred induction for newly diagnosed myeloma? A, bortezomib dexamethasone, B, lenalidomide and dexamethasone, 3, bortezomib, thalidomide and dexamethasone, D, bortezomib, lenalidomide and dexamethasone, and E, other. So most of you prefer bortezomib and thalidomide and dexamethasone. That's very interesting. I think if you asked this question in the United States, the answer at this time would probably be D. Next slide, please. What is your goal of treatment for newly diagnosed multiple myeloma? Disease control, or B, a curative approach, that is to maximize the depth of the complete remission? Maestro? Well, that's the ideal. I'm not sure we're there yet, but I think maximizing your CR is probably a good idea. Next slide, please. That's it. Okay, thank you very much.